Welcome back. My next guest is Dr. Kevin Denehy, who is an orthopedic surgeon, specializes in hips and knees with Bluegrass Orthopedics.
Yes.
Welcome.
Thank you for having me.
Well, now, everybody has joint pain. I have joint pain, and it seems to get worse the older you get, but how do you know when joint pain is something you really ought to worry about?
Sure. It's a very common complaint, and a lot of people suffer from hip and knee pain and arthritis. Most of it usually is related to your quality of life. How much is that pain affecting you? Are you not able to do the activities that you like to do and want to do? You know, things like sleeping is a big cue for me, that people have trouble sleeping because their joints wake them up at night because they're hurting them. That's usually time when it's, really important to get into either see your family doctor or an orthopedic specialist to be evaluated.
Now, a lot of stuff you can tell by physical exam, but you got to do some imaging to make a diagnosis.
Yes, sir. Yeah. So, x-rays are usually our mainstay of treatment or diagnosis for arthritis in the hip and the knee. Usually weight-bearing x-rays, because that gives us a good idea of what joint space you have left. What happens in arthritis is that over time the cartilage in the knee wears out. The cartilage is a smooth cap that, kind of protects the end of the joints in the hip and the knee, and over time it can wear down. The cartilage doesn't have nerve endings, so it usually glides back and forth very easily, and it's not painful. When the cartilage wears out, the exposed bone is roughened and it has nerve endings, and so it can be painful for you. And the x-rays show us a good sign when that cartilage is worn out and the bone is touching the bone. That's usually a time when you really start to need intervention into it.
Now, you talk about intervention. I know you're a surgeon, you operated, but
Sure.
Before we get to that, are there things you can do to help the symptoms?
Absolutely. There's usually 5 kind of major things that we use to non-operatively treat arthritis before we get to surgery. So the first thing, and most people do this on their own, is activity modification. So kind of avoid the things that hurt you, and that's pretty straightforward. Then a lot of times people do physical therapy, work on strengthening the muscles, ligaments, tendons around the hip or the knee, and that a lot of times can offload the stress that's going through the knee. Sometimes we can do some bracing. Bracing can kind of, again, help offload the stresses that are across the knee that are causing pain. Then we usually jump to anti-inflammatory medications that you can take orally. So things that people can get over the counter like Motrin, or some kind of stronger prescription ones like meloxicam or Mobic. If those start to fail, then we kind of go into more interventions like injections. A lot of times people will get relief from things like a cortisone or steroid injection. And then sometimes people will use what we call gel or hyaluronic acid injections. People also heard of them as rooster comb injections. Those work in different ways. The steroid injections cut down on the inflammation inside the knee. The gel injections work to kind of push some of the fluid inside the knee back into the cartilage, give it a little bit more cushion to give you some more longevity.
Okay, so if those don't work, you end up with an operation, and you're doing some new techniques, both cementless in the knee and anterior approach in the hip. Tell me about those.
Sure. So, one of the questions I commonly get asked when people are indicated for joint replacement is, how long is this going to last me, doc? And, it's a hard question to answer, but historically, as in the replacements, were put into place with cement. And you imagine the cement can kind of be like the grout in your bathroom, and it wears down over time, especially if you're young, you're active. Even some people that are slightly overweight can put more stress across it and cause that cement to break down a little bit quicker. And when that cement breaks down, the parts can become loose. So newer technology has been developed where the coating on the implant's done and with a 3D printing, and they can kind of actually 3D print the metals, the titanium, onto the implants, and it's the exact kind of pore size that a bone cell wants to grow into. So it gets really good initial fixation, and then the bone grows into that over time. And these are newer implants, newer technology, but ideally, if these get good bony ingrowth, theoretically that bond would be permanent. And it wouldn't be like the cement that could break down over time, because your bone would remodel and adjust, and hopefully that implant would bond to your bone for a lifetime.
Lifetime. Well,
Yeah.
that's a lot different than normal. Now, the hip's a little different too in terms of different approaches and how you put it in.
Absolutely. So historically, most people did an approach called a posterior approach, or where there's incision kind of in the back or the side of your hip. When you did that approach, you have to kind of split one of the big muscles in the back, and because of that, there's a lot of muscle damage. It can be sore and painful to kind of get up right after surgery. So a newer approach that's been developed over the last 10 years or so, and it's catching on more and more, is called an anterior approach to the hip. A smaller incision in the front of the hip where we're able to go in between muscles instead of through them. For the patient, what you see that as is less pain post-operatively, earlier functional scores, you're up moving faster, and recovery is a lot quicker. Now, usually by about 3 to 4 months, people are about the same in terms of what they're able to do in the hip, whether you go from the front or the back, but that early recovery is definitely a lot faster in the anterior hip group.
And you're getting, when you say earlier recovery, it's getting to be a better procedure, easier, and more functional quicker.
Absolutely. 10, 15 years ago when people had hip or knee replacements, they were in the hospital for a week and then spent a month in rehab. And that's no longer the case. A lot of these surgeries, because of the newer techniques, are able to be performed even in the outpatient basis. So people are going home the same day. Some patients stay in the hospital overnight and go home the next day. But almost, I would say 95% of my patients, the most they'll stay in the hospital is one night and then they're home the next day. We've gotten better at decreasing our transfusion rates, less blood loss, better pain control, and we do a lot of things to help accomplish that. But what that means is you're out of the hospital, away from where there's sick people with infections that could get you infected, which is a pretty big catastrophe in joint replacement. So we like to avoid that, and you want to get back home and recovering in your own house, which is a lot nicer for most people, and they appreciate that.
Great information. So if you've got joint pain, there's a lot of new treatments out there. We'll be right back.